We will give a couple more minutes for more people to join, and then we'll go ahead and start. Okay, we can go ahead and start. Good afternoon, everyone. Welcome to the AAP section on neonatal perinatal medicine, TCAN Virtual Journal Club session. Thank you for joining us this afternoon. Housekeeping announcements. Please mute yourselves if you're not speaking. If you have any questions to our faculty mentors, please send your questions to either myself or Viral Jain, who's my co-host this afternoon, or use raise your hand feature on Zoom to voice your questions. Please do not interrupt the presenter directly. Please fill out the feedback survey that is distributed at the end of this session to help improve future sessions. Our presenter, faculty mentors, and moderators may pause the presentation for questions at any time to make this more engaging and educational. So the trial we'll be discussing this afternoon is the HELIX trial, hypothermia for moderate or severe neonatal encephalopathy in low-income and middle-income countries, a randomized controlled trial in India, Sri Lanka, and Bangladesh. This paper will be presented by Dr. Angelina June, who is a neonatal fellow at the University of Virginia Neonatal Perinatal Medicine Fellowship Program, and also a member of the TCAN Executive Council. We are happy to have Dr. June present this paper this afternoon. And we are now excited and honored to introduce our faculty mentors for this discussion. And we thank you on behalf of TCAN for agreeing to do this. First, I would like to welcome Dr. Sita Shankaran. Dr. Sita Shankaran is a professor of pediatrics at Wayne State University and a neonatologist at Children's Hospital of Michigan. Dr. Shankaran, who needs no introduction, is a pioneer in the field of finding therapies to improve the outcomes of infants with HIE. She has led several landmark trials in the therapeutic hypothermia arena, and her contributions to the field are immense. Her work was recognized with several awards, including the most recent 2021 AAP Section on Neonatal Perinatal Medicine Landmark Award. Thank you, Dr. Shankaran, for agreeing to mentor this session. And now my colleague, Dr. Viral Jain, will introduce Dr. Ambalwan.
It's my pleasure to introduce Dr. Ambal. Many of you may know Dr. Ambal. He's the professor of pediatrics at University of Alabama at Birmingham. He's also the Virginia Walker Jones Endowed Chair in Neonatology at UAB and Children's of Alabama, and also serves as the program director for the Neonatology Fellowship there. Dr. Ambal, as you know, is very interested in research. He's the director of Trent program and the division of neonatal research at UAB. He loves education. He loves teaching. He's trained multiple junior faculties for K and R grant, and I'm one of them. He has a phenomenal career with more than 350 publications to date for it, and he has also served as PI of many NIH studies and has chaired multiple neonatal research network sections and studies. So we are very grateful to have him join us for today's session. Okay, we'll let Dr. June take over.
All right. So hello, my name is Angelina June, and I'm a second year, soon to be third year neonatology fellow at the University of Virginia. I am passionate about both neonatal neurology and global health, so I'm very grateful for this opportunity to present the HELIX trial as part of the 52 and 52 Virtual Journal Club. I want to thank Dr. Jane for remotely mentoring me and looking through my slides to present at this, as well as my local mentors, Dr. Burnstead, Dr. Sullivan, and Dr. Shah. Thank you also to Dr. Shankaran and Dr. Amble for taking the time to be here as mentors and experts. It is truly an honor and a privilege. All right, I have no disclosures or conflicts of interest. The Concert 2010 checklist will serve as the structure of this presentation, and I have omitted checklist items that are not applicable. So the article we're talking about today is the HELIX trial, hypothermia for moderate or severe encephalopathy in low-income and middle-income countries, a randomized controlled trial in India, Sri Lanka, and Bangladesh. This is published in the Lancet Global Health, August 3rd, 2021. The title clearly describes the study and the study setting and identifies it as a randomized controlled trial. It clearly states that the participant low-income and middle-income countries as India, Sri Lanka, and Bangladesh. As you can see, there were many members of the HELIX trial group. It was a tremendous international collaboration that included members from the UK, US, India, Sri Lanka, and Bangladesh. The abstract, or the study summary, was very well structured. It gave a succinct background of why the study is important, the methods identified, inclusion criteria, which we'll discuss in subsequent slides, as well as a description of the care setting to orient readers perhaps not familiar with care facilities in the countries studied. It identified the primary outcomes, which was a combined endpoint of death or moderate or severe disability at 18 to 22 months. Moving on, this was an excellent summary of the findings, including a discussion of no adverse events being causally related to the study intervention or therapeutic hypothermia. The conclusion or interpretation statement was both easy to understand, and the recommendation was strongly worded that therapeutic hypothermia should not be offered as treatment for neonatal encephalopathy in low-income and middle-income countries, even when tertiary neonatal intensive care facilities are available. One part of the supplemental material that I thought was really super was how the abstract was translated into multiple languages to maximize accessibility, especially for providers in the studied countries. I just have Telugu and Bangla shown here, but it was translated by the authors into 8 total languages. And this is just a quick glossary of terms that we'll refer to: LMIC, low income and middle income countries, therapeutic hypothermia, TH, HI, hypoxia ischemia, HIE, hypoxic ischemic encephalopathy. So a quick review of the hypothesized pathophys underlying neonatal HIE. Clinical and experimental studies show that neuronal death occurs in 2 phases following HI. So following a severe HI insult, there may be immediate primary neuronal death due to cellular hypoxia and the depletion of high energy stores. So that's primary energy failure. After a latent period of about 6 hours, the secondary phase of delayed neuronal death begins. And this phase is specifically associated with encephalopathy and increased seizure activity. The secondary phase is the primary contributor towards HI injury and ultimate cell loss. There is a therapeutic window of opportunity that exists in the interval following resuscitation of the asphyxiated newborn before the secondary phase of impaired energy metabolism and injury. And this window is where TH is thought to have the most therapeutic effect. So neonatal encephalopathy causes significant morbidity and mortality worldwide, the majority of which occurs in LMICs. In terms of evidence for TH and HIE, the authors cite 1 Cochrane review and 3 systematic reviews from high-income countries that conclude that TH reduces death and disability after neonatal encephalopathy. These are the 3 studies cited, the countries they were performed in, as well as the Cochrane review, which we'll take a closer look at. So these 4 plots are from the Cochrane review mentioned as it relates to the primary outcome and some secondary outcomes of the HELIX trial. So for orientation, the left favors hypothermia and the right favors standard care. The forest plot from the Cochrane review here shows that the outcome of death or major neurodevelopmental disability in survivors assessed. The meta-analysis showed that there was a significant reduction of this outcome with therapeutic hypothermia. And I just wanted to note that Zhao 2010 had selective head cooling, but was the only study here in this list that was done in an LMIC, China. All other studies included were conducted in high income countries. And these are the two Cochrane Review forest plots looking at mortality and major neurodevelopmental disability independently. Both show significant reduction of these outcomes with TH, and thus both outcomes favor hypothermia. So where does that leave LMICs? Keeping in mind that CoolCap, NICHD, TOBY, and almost all the studies included in the Cochrane Review were from high-income countries. There was a paper by Abate et al. In 2021 where they completed a meta-analysis of 28 RCTs with 3,592 participants to look at the pooled relative risk of mortality of neonates with HIE in a more global context. So this forest plot is a subgroup analysis by country level of income on the effects of TH on mortality among neonates with HIE. In this plot, the orientation is flipped. So left favors standard care and right favors hypothermia. So their meta-analysis concluded that selective head cooling and whole body cooling methods are effective in reducing mortality in HIE, and that low-income countries benefit the most from the therapy. And their conclusion was that health professionals should consider offering TH as part of routine clinical care to newborns with HIE, especially in low-income countries. Prior to this, the HELIX paper reminds us that the International Liaison Committee on Resuscitation recommended TH using low-cost cooling devices in LMICs, but did not acknowledge that the existing evidence was weak. And that leads us to our gap in knowledge. There was no large, adequately powered, randomized control study on the use of TH for neonatal HIE in LMICs. I also wanted to note that prior to developing the HELIX study protocol, the HELIX group conducted their own systematic review of RCTs and LMICs. They looked at 15 RCTs that used head cooling and whole body cooling, but using low cost materials, such as gel packs, phase change material, and water bottles. In their pooled data, there was also a significant reduction in death with cooling, but each individual trial was small, were pilot studies, and the authors also state that they were of poor quality and almost no data was collected on long-term neurodevelopmental outcomes. So after synthesizing this background information, the objective of HELIX was to examine whether therapeutic hypothermia alongside optimal supportive intensive care reduces death or moderate or severe disability after neonatal encephalopathy in South Asia. Overall, they looked at full-term babies with moderate or severe neonatal encephalopathy admitted to tertiary NICUs and LMICs. TH was initiated within 6 hours of birth and continued for 72 hours, and outcomes at 12 to 22 months were compared to usual care. And I want to point out here that although the authors named South Asia in their objective, it seemed to me their overall goal is to have this trial as a reference for all LMICs, not just South Asia. In the paper, they state that the findings in South Asia are unlikely to change, for example, in sub-Saharan Africa. I wanted to pause here and ask a few questions for our mentors. Why were these particular 3 countries chosen? And also prior to the study, did you think that TH would be beneficial in terms of reducing mortality and improving neurodevelopmental outcomes?
So Sita, you want to go ahead?
Yeah. You know, we had actually done a pilot study that we did in the hospital in Calicut Medical College in Kerala to see if cooling was feasible in an LMIC setting. So we did do that first and published that to see, and noted that it was possible using a servo-controlled mechanism that you could cool these infants and you could get the MRIs and you could get the EEGs. Yes, the objective was really to see whether findings in the high-income countries could be replicated, you know, in LMICs. That was the purpose.
Yeah, and I'm not really sure why only these centers in these countries were selected. I think probably more based on. Yeah, go ahead, Sita.
Well, the PI and the team is really from Imperial College in the UK in London. So it is where they have the affiliations which were really focused more in India. The majority of the affiliations were in India and Bangladesh and Sri Lanka.
So, Dr. Shankar, as Dr. June pointed out.
Uh-huh.
So was there any motivation behind doing this study, considering we had antenatal steroids? Initial studies showed that they may be harmful to do it in low middle income countries. What decided you to study this topic, which is pretty clearly proven in high income countries to be working so well?
Right. I mean, it is certainly shown in the high income countries, and you have to remember that it was being used in India. In some of the centers were using cooling, and there really was no follow-up data on any of the infants who were being cooled. So we did not know whether there was, first of all, safety of cooling in LMICs and whether there was efficacy in cooling. So that's why the study was planned, and it was planned in phases. First to do a pilot, and then to develop the major trial itself. And it did take a lot of working with not just with the health departments, with the government, et cetera, et cetera.
Thank you for the insight. Dr. June, you can take it.
Moving on to the method. So the trial design was an open label, multi-country randomized control trial with a 1-to-1 allocation ratio. The locations were 7 large public sector NICUs in India, which had 5 sites, Sri Lanka with 1 site, and Bangladesh with 1 site. And all sites had assisted ventilation, cardiovascular monitoring, MRI, and a 2-tier management system of trainees and attendings experienced with therapeutic hypothermia. In terms of our screening criteria, all infants had to be greater than or equal to 36 weeks gestational age with a birth weight greater than or equal to 1.8 kg and admitted to the NICU within 6 hours of birth. The cord blood gas was not included as it may not have been available at all sites, but I will note many of the previous TH trials included cord blood gas, pH, and acidosis as part of their TH criteria. Furthermore, the APGAR at 5 minutes differs from the 10-minute APGAR commonly used in the previous TH trials. As you can see, the eligibility criteria here, the infants had to have both of these, a need for continued resuscitation at 5 minutes of age, or an APGAR score of less than 6 at 5 minutes if born in hospital, or an absence of crying by 5 minutes of age, and evidence of moderate or severe encephalopathy between 1 and 6 hours of age. And the SARNET staging was done by a certified examiner after admission to the NICU. I also wanted to ask the mentors, what was the discussion leading up to creating these criteria that differed from the previous TH trials that were mentioned in the Cochrane review, for example?
Well, part of it is that, we knew that we would not have cord blood gases available on all the infants. So that's why after some discussion, we came up with criteria which closely matched the criteria from the NICHD trials.
Thank you. In terms of our interventions, our control group had usual NICU care, including vents, pressure support, and specifically the avoidance of iatrogenic hyperthermia. They did this by restricting overhead radiant warmers during resuscitation and setting lower thresholds in the servo-controlled warmers. For the hypothermia group, same usual NICU care as above, but whole body cooling to 33.5. It was a rectal temperature for 72 hours, an automated servo-controlled rewarming at 0.5 degrees Celsius per hour, and passive cooling prior to the NICU admission was not permitted. They used the same cooling device as was used in the UK. And unlike the previous studies cited from LMICs, they did not use those low-cost cooling methods.
Just to briefly mention, I think that point that you made, setting lower thresholds in servo control warmers at 36 degrees, I think that's one of the critical things we may want to revisit, because avoiding hyperthermia is probably key to reducing brain injury in the control group.
Right. Because the adult trials for cardiac arrest and the pediatric, both in-hospital cardiac arrest and out-of-hospital cardiac arrest, showed that hypothermia was equivalent to targeted normothermia in the control group.
In terms of our outcomes, the primary outcome was death or a moderate or severe disability at 18 to 22 months. It was assessed via Bayley-3 scores, gross motor function classification, hearing impairment and enhancement requirements, and or persistent seizure disorder. The definitions used for severe and moderate disability were similar to COOLCAP, NCHD, NICHD, and TOBY, and some of the other studies that we looked at in that Cochrane review. The short-term secondary outcomes included death before hospital discharge, a major intracranial bleed, or an abnormal neurological exam on discharge. The long-term secondary outcomes were death from any cause at 18 months, severe disability among survivors, and microcephaly assessed at 18 to 22 months. And then there's also exploratory MRI biomarkers, neurodevelopmental, and growth outcomes. Another question for the mentors: what are your thoughts on the need to adapt Bayley-3s to LMICs? So there's been a few studies that have looked at modified Baileys to fit socioeconomic and cultural norms. For instance, in the Bayley, using scissors as part of the fine motor scale, but that might not be a common household item for some people. Additionally, names for colors, use of plurals, and understanding pronouns can also differ by language. I know in this study, Baileys were done in the language of the country,
Yes.
but I was wondering what you thought about those modifications others have studied.
Yeah, the Baileys were done, the Bayley assessors were initially trained in the UK, and then the Baileys were done in the language of the children from, whichever state that they came from. So we really didn't feel, we thought the Bayley, as you know, the Bayley is probably the most recognized neurodevelopmental assessment tool. And certainly for the hypothermia trials, the Bayley-3 has been the one that's been, used the most. And then for childhood outcome, you have the IQ scores. So for comparison and for, those type of evaluations, we thought the Bayley-3 would be the best. And then the GM-FC classification, of course, is something that was also the physicians doing the neuro exams were trained to do that. And that also is quite standard across the world. So I think, we were trying to get outcomes that could be seen as comparable to outcomes in the high-income trials.
Yes, I think it's important to have a validated tool like the Bayley-3 and have the same tool used across all the centers by certified examiners. So I think that's the key critical point. The other thing I would mention is these are 2-year outcomes, and how valid they are when you look at outcomes at, say, 5 to 6 years of age or later. Again, we don't know in this population.
Right. I agree.
All right, moving to the sample size calculation, it was calculated to detect a 30% relative risk reduction in the primary outcome, 80% power, allowing for 10% loss to follow-up. So all in all, calculated to be a sample size of 204 per group. And also the Independent Data Monitoring Committee monitored progress every 6 months during the study. And during all checkpoints, this group unanimously voted for this trial to continue.
Yeah, and the Independent Data Committee included members from UK, the US, and India, and was chaired by Abbott Laptock, who's one of the NICHD hypothermia experts.
For the randomization, it was a 1-to-1 allocation ratio. It was a web-based randomization system with sealed envelope. It was computer generated. A minimization method was used to control for encephalopathy state and study center. So what this means is that they use this to minimize imbalance between the number of patients in each treatment group by encephalopathy stage and study center. So if a center, for example, had more hypothermia armed subjects, the randomization software would take that into account and use 1 to 0.85 instead of 1-to-1. So the next patient would be favored to be in the control arm. Clinical team members approached parents for consent. Study personnel entered clinical details and randomized participants. Blinding of the intervention was not possible. However, the MR biomarker analysis and the neurodevelopmental outcomes assessment was blinded. This was a primary analysis on an intention to treat basis, and the differences in outcomes between study groups quantified as risk ratios with a 95% confidence interval. And I've drawn a table on the right of the comparisons and what statistical tests were used for those comparisons. The recruitment period was between August 15, 2015 to February 15, 2019 of infants with moderate to severe encephalopathy. The mild and no encephalopathy infants were excluded. They had really amazing follow-up. Out of 400 some infants, only 9 total were lost to follow-up. That's 0.02%. Looking at all the participants allocated to the hypothermia group, it started off as slightly less than the calculated sample size, the 202 versus the 204, and both groups in the end had slightly less than the calculated sample size by the end of the trial. The follow-up dates were between January 6, 2017 to September 27, 2020. Some commentaries on the study discuss the high number of inpatient deaths in the hypothermia arm versus normothermia, 72 versus 49. So I have a follow-up slide on that right here. So I just created a table of the causes of death in the hypothermia group, which were mostly related to asphyxial brain injury related complications. Of note, none of the deaths were related to withdrawal of life support, although 3 infants in the hypothermia group and 7 infants in the control group were discharged against medical advice. So these numbers are either a percentage of patients, a mean with a standard deviation, or a median IQR. So some baseline data that I noted was that these were relatively young mothers in their mid-20s between both groups. Among the complications of pregnancy, high percentage of meconium stain fluid. Could this be indicative of more perinatal fetal stress or a subacute process? There was also relatively low percentage of perinatal sentinel events, which also may point to more subacute processes underlying the encephalopathy. Not surprising, most were actually vaginal births, and most infants were born at another hospital with capabilities unknown, but there's a breakdown of the different hospitals that these babies were transferred from below here. It was a little bit surprising to me how few infants were actually born at home, and that all home births were from one site in Bangladesh. And I just thought it was interesting also to note that there was more males than females in both groups, but that this was balanced between both groups.
Dr. June, in the supplementary material, any information on why these patients were referred to the hospital where the study was being conducted from the birth hospital?
I didn't see that personally in the supplementary material, but I would love to hear from our mentors if that was something discussed.
Well, I mean, it was similar to, just the referral patterns that there were calls for admission, and if the baby fit the criteria and could arrive within 6 hours, they really tried to do that. So there was a lot of publicity given to the study, a lot of a lot of lay language material that was distributed. So there was awareness of the study. There was when the study was launched, there was publicity. So I think people were aware that the study was ongoing.
And Dr. Shankaran, around that time, was it a common practice to still offer therapeutic hypothermia while the study was ongoing? And how did the clinicians feel randomizing babies to routine care without therapeutic hypothermia in some of the other hospitals within the area? Well,
yeah, there were a number of what we call private hospitals in India, which are well-resourced hospitals with private practitioners that had cool babies and continued to cool babies. But these centers were selected, and there was, preparation in the launching phase of the study to ensure that there was equipoise in these institutions to randomize the infants. So the study sites were those where the physicians still had a question, is hypothermia safe and effective?
I just want to make a couple of other points. One is that you mentioned that many of the infants are born in the hospital. And in India, Bangladesh, and Sri Lanka, they are now highly urbanized. Maybe
Right.
50 to 100 years ago, there were a lot of babies being born at home, but now the majority of births occur in the
Yes.
hospital.
Yes.
So that's the important thing. The other thing you
Yes.
should note is that there's a preponderance of males. It's about 2/3 male to 1/3 female. So again, there is still in this 21st century, there is sometimes a preference for male infants, which you might pick up in the form of preferential referral or treatment.
Mhm.
So it's not that there are more asphyxiated male infants, it's about 50-50
Yeah.
in the other trials.
Mhm.
That was definitely something I was wondering too. And even for on this slide, the parents that did not want to be part of the trial, I was wondering if there was a gender breakdown for that. I also have some
No.
mental health experience too, and
Yeah.
I know that can be a reality too, that there's a male preference, but just a question.
Yes. There wasn't actually there is the other thing that should be mentioned was that the consenting process was videotaped for every single infant and was reviewed by a group of researchers who have another publication coming out on, and who've already had one publication on consenting and, the reactions of the parents, etc. So none of us felt that there was a preference for, as Ambal said, that more male infants are asphyxiated, or that there was a preferential referral of male infants. No, that was not there.
Thank you, Dr.
The point I'd make on this slide is the relatively low frequency of acute perinatal sentinel events, which were certainly much higher in the high income setting trials.
And some of the patients that were included due to the lack of equipment, Dr. Shankaran, was it just because the limited number of equipment that were at the hospital that were already being used? Or
Yes.
Thank you.
Yeah, which happens, I think, which happened also in a couple of the trials that were done in the US also. So equipment availability is important.
Thank you.
Thank you. This is a continuation of this table. So other things noted was that both groups had really poor cord blood pHs upon admission. Again, this is not an inclusion criteria to improve the generalizability, but all infants that were admitted to the NICU did have a blood pH drawn. A high percentage of infants required mechanical ventilation in both groups. Most infants were referred from other hospitals, and it took an average of 3 hours to arrive when they were referred from another hospital. And also almost 75% of infants had clinical seizures in both groups. And I have a follow-up slide on that next, but most infants were scored as moderate, which surprised me a little bit just because looking at that cord blood gas and then also looking at that high percentage of seizures, I was expecting more severe encephalopathy.
Well, the staging of encephalopathy is based on your neuro exam. So the neuro exam shows moderate encephalopathy, and if you have seizures, you're still moderate encephalopathy. And even in the high income trials, we've always had a higher percentage of moderate compared to severe.
I see.
Yeah, one thing I have thought about is while these examiners were certified as to the neuro exam for encephalopathy, I don't know how they would have standardized assessment of seizures by clinical assignment. So meaning that a lot of people actually look at decerebrate posturing and call that a seizure rather than calling it decerebrate posturing, which may be seen in encephalopathy.
Right. For the training of the physician examiners, we requested permission from the NICHD Neonatal Research Network, and we actually used the same training slides that we had developed for the network for this study. So the same slides, the same definitions of the categories of moderate and severe encephalopathy, the same definitions of seizures was used. And then I supervised, so then Dr. Thayil and I supervised the whole thing.
Which is a perfect segue to the next slide that I want to follow up to look at those clinical seizures, since a lot of the commentary was on that as well. Looking at clinical seizures in previous cooling trials. So HELIX showed that higher percentage of clinical seizures compared to most studies, except I think ICE and CoolCap had comparable percentage of seizures looking at this data in the Cochrane review. And this is the it's the chart of seizures during initial hospitalization from the Cochrane review. And of note, there was no clear benefit of TH when clinical seizures were observed at hospitalization here. It was just pretty much borderline significance. It just made me think the seizures are more common in that secondary injury phase of hypoxia, which falls outside that optimal therapeutic window. So were these infants already outside of the window? That's the reason why we're seeing more clinical seizures. Was this why the effectiveness of TH was reduced? But also, I also recognize that it's difficult to just look at seizures clinically without AEG capabilities. How many of those were true seizures?
Right. Yeah, you're absolutely right. The remarkable thing was the early onset of seizures, though, earlier than we've seen in the HIC trials. So both the frequency as well as the early onset of seizures was something that was very impressive for this trial.
Yes, and I think just want to mention one other thing. So we call it hypoxic ischemic encephalopathy, but I would put the emphasis on the word ischemia rather than hypoxia, because pure hypoxia by itself is well tolerated. It's ischemia, which is the bigger issue.
Right. Yeah.
And I find it particularly surprising that there was, like you mentioned, that there were not too many more sentinel events given the
Exactly.
very early
presentation
of seizures.
Yeah, we were really, that was an unexpected finding, that the frequency of sentinel events was lower in this trial, which as pointed out, could be that it was not something that was acute peripartum, which makes it more likely to be reversible and treatable, as we see in the HIC trials.
Yeah.
So, and of course, there is preclinical work, mainly from Alistair Gunn's group, where they look at, subacute repeated injury in the preclinical model, and how those models do not respond well to cooling when you have repeated, low-grade repeated injury.
So I have a question from audience regarding this topic, considering the low incidence of acute events in this group. Was the selection of the eligibility criteria the core issue why we did not see a difference in the result, that we did not select the right babies?
I see. I have a problem with that, and that was raised in the umpteen letters to the editor that we received. The criteria that you choose for a trial is the highest risk that you think that the infant has. So based on the criteria seen in the trials performed in the HICs, these were comparable. So, and we had no idea that the frequency of PSEs, the perinatal sentinel events, was going to be lower in this group. We didn't know that when we started the study, certainly. So it was only at the end of the study we realized that, the frequency of sentinel events is so much lower. So,
Dr.
Yeah.
I'm sorry, go ahead, Dr. Shankar.
No, so the inclusion criteria was selected to try and capture the babies who had birth acidosis and required resuscitation, either birth or early acidosis or the resuscitation. That will be tried to capture that group of infants.
Dr. Shankar and Dr. Ambalwan, would you mind shedding some light on how fetal monitoring is usually conducted at some of these centers? Is it that we are not looking for these events as closely as we would in a high income or high resource country, that we are not finding these events, or is it just it just happened to be a lower incidence, because most of the patients going to the non-private hospitals or government setups, typically what we call them, usually rush in like at the end or live far away from that center. Do you think that may have played a role in this?
You know, in HELIX, the majority of women had good prenatal care, and they came in for their scheduled visits towards the end of the pregnancy. And this has led to a study that is being done now called the PREVENT study, which I think you may have heard some of the presentations at the PAS, you know, where 60,000 women are being evaluated. So actually, as Ambal said, the care has changed quite a bit. I mean, these are all majority of hospital births. The mothers, it's not that they walk in. I mean, they come in early and they are monitored. So, you know, so I can't tell you why it was that we had the lower perinatal sentinel events. So that is one of the things that's being, you know, really investigated now, as to whether there is, you know, injury. Is it acute on chronic injury? That's the question. Or acute on repetitive injury.
I mean, if you look at this table, you see that the fetal heart rate decelerations were pretty low in number in both groups.
Yeah. Mm-hmm.
But again, the issue is many of these mothers were probably monitored using manual auscultation rather than electronic fetal monitoring. So if we had the fetal heart rate tracings of in a large number of this cohort, that might give more information as to the accuracy of the fetal distress.
And it was pretty balanced between both groups.
Yes.
So it wasn't, yeah. The other thing also that is important, that the you know, infection was not that high. I mean, it was pneumocystis was 18 and 14%. Sometimes when you look at the data coming out of Malawi and, you know, Uganda, it is different than what it is here.
Thank you so much. Dr. June.
Great. So moving on to the primary composite outcome of death or moderate or severe disability, it was not different among the two groups, that primary outcome. And a composite outcome was chosen to address the competing effects of death and disability. So an intervention that would increase death in infants who would otherwise survive with disability might appear falsely neuroprotective. However, the predefined secondary outcome of death up until 18 months had a statistically significant increase in the hypothermia versus the control group. And then in terms of the other exploratory secondary outcomes of the survivors, there's no significant difference in the Bailey scores, hearing or vision impairment, persistent seizure disorder. However, there was less disabling cerebral palsy in the hypothermia group, which I thought was very interesting. Another part of this was the predefined secondary outcomes during hospitalization. I've highlighted some of the statistically significant findings, and we looked at causes of death in the previous slide. And it was interesting to put these findings in the context of that. So there is a statistically significant increase in gastric bleeding, persistent hypotension, coagulopathy, severe thrombocytopenia, metabolic acidosis, and the length of hospital stay in the hypothermia group versus the control group. And in terms of MRI findings, which was another great strength of the study, I added this image to quickly talk about the patterns of injury in HIE. So diffuse pattern of injury is seen in severe and prolonged insults. All levels of the neuroaxes are affected. As Dr. Shankaran was saying, this has been seen in preclinical studies of repeated hypoxia in near-term fetal sheep, for instance, versus a deep nuclear brainstem pattern, which is associated with a severe and abrupt insult, and one would see more basal ganglia, thalamus, brainstem involvement. It's more common in emergency C-sections or need for intense resuscitation. So in this study, there was 284 participants that all got MRIs, and the median age was 14 days of life. In this study, the MRI showed a high burden of white matter injury, but a low burden of the basal ganglia and thalamic injury. And so that brings the question, does this mean there is more infants who suffered that severe and prolonged insult versus an acute insult? And then also the question is TH more effective in treating those acute insults rather than those prolonged repeated hypoxic events? And so the major takeaway in this multi-country RCT done in tertiary NICUs in India, Sri Lanka, and Bangladesh, TH alongside optimal NICU care did not reduce composite primary outcome of death or moderate to severe disability, but increased death alone. There's an increased incidence of death at all sites in the hypothermia group, irrespective of place of birth, perinatal sentinel events, growth restriction, or coexistent sepsis. The HELIX trial results do not support the use of TH for HIE and LMICs. This was the largest cooling trial in the world thus far, the only phase 3 clinical trial in LMIC. And given this data, essentially 1 infant will die for every 9 treated with therapeutic hypothermia. And then just quick other information of where this was registered and the source of the funders. And I just wanted to move into the open discussion of this part. Is HELIX applicable to LMICs beyond the country studied as the author suggests? And what can we extrapolate from HELIX about low-cost cooling materials, given that they use the same cooling method as they do in the UK?
So I think one of the things to take away from this study is you're having this trial showing no overall benefit, though of course if you look at the subgroups and you look only at survivors versus then you have a reduction in CP, you have a reduction in disability in the ones who survive. But on the other hand, you have all the published meta-analysis and all the multiple trials from the, what you might say, the higher income countries. So is it because we have a different population of infants, or is it, should you assume that if the population is the same, you would have similar results in both settings? Or if you were to have an infant with an acute perinatal insult in a developing country, should you not give them hypothermia because you go with the results of this trial?
And that's some of the editorials that have come out saying that maybe you should not say do not use it, but use it for selected infants. And the most clear thing, at least up to now, is maybe if you have an infant who is acidotic, in a perinatal center and has an acute perinatal sentinel event like cord prolapse or uterine rupture, then should cooling be offered? And I think, that to me does not sound unreasonable.
Did cooling stop in the centers that were studied or part of the study because of the result of the study? Okay.
Yes. Yeah.
I guess one other thing that we were discussing was in a lot of centers and LMICs, the fact that they have cooling is it's something of benefit to their hospital that they would want to advertise. So I was just thinking about what is their, besides the health of the infant, what would be their incentive to stop cooling if they already had cooling, and have other centers besides the ones that were studied actually stopped cooling?
That's a very good question, because there are centers that I'm aware of now that have not stopped cooling, because cooling is an economic benefit both to the institution and to the physicians themselves. So, and so I think people have to make decisions on their own as to what they would do.
So I think the other question would be, what can we draw from this for clinical practice in the United States and the UK and other countries? So should we be offering therapeutic hypothermia for infants, say, who are having seizures soon after birth, who probably had a subacute insult? So would it be appropriate to provide hypothermia for them, knowing it may not help and it might potentially, you're exposing them to the risks of hypothermia as well?
Well, you know my favorite question,
Yes.
and that is, why are we cooling all these mild HIE kids?
Yes, that's
You
true.
know, why? I've been asking that for 3 years now, and people are merrily cooling them. I mean, more and more and more. Every survey comes out with more people cooling mild HIE kids without any follow-up data, which really concerns me.
Yes, very concerning.
We have several questions from our audience, and I'll tag team and ask Dr. Shankaran one question and Dr. Ambal another, and then we'll go into the additional considerations and final comments and by Dr. June. So, Dr. Ambal, first question is to you from our audience would be, if at all, if the patients from the private hospital settings in India were included in the study, do you think the results would have been different in terms of, one, identifying the sentinel events, two, in terms of overall primary and secondary outcomes that we've looked at?
So there is a lot of heterogeneity in the private hospitals. I think that's the first. It's not a very homogeneous population. There are some centers which provide really excellent care, and there are others which basically don't do a very good job. So it depends a lot on, say, factors like what is their nursing or staffing ratio. I mean, is it 1:1 or 1:2? Is it what kind of infrastructure do they have in terms of fetal monitoring, and who exactly is staffing them? Is it a neonatologist or just a pediatrician who comes in from home, looks at a baby and goes back home? So there's a lot of variation in practice. So I'm not sure that results would necessarily be better in a different institution.
And I would also mention that these hospitals had very high delivery rates, and you don't necessarily see high delivery rates in the private hospitals because they are, they have all paying patients. So the rate of delivery is not very high.
And is the patient population so different in the low and middle income resource countries that the results are so different from an intervention that has been helpful and proven to be significantly helpful in a high income resource country? That's another question from one of our audience.
Yeah, which is why, we are questioning or going to examine the population differences. And I know the group is going to be looking at genetic markers also, which will be really interesting. They've started working on that. Then they could very well be population differences, and we need to look at that. Yeah.
And like, would the conclusion of this may need to be abandoned in low and middle income resource countries altogether? Do you think that was too strong, or would that have been different if all different subsets of population were included?
I think it is probably too strong to begin with. Yeah, I think like Dr. Shankaran mentioned, I think there is definitely a population which does improve with hypothermia, and probably we need better patient selection. And I think, having said that, in the infants who are not getting hypothermia, I think attention to maintaining normothermia and avoiding hypothermia is critical.
Right. Yeah. And if the infants are cooled, they should be followed up at least to the age of 2 years, because we have shown from both the TOBI trial and the NICHD trial, where we have 6 to 7 year follow-up, that it is the protection does persist. So the earliest age that you can evaluate these children is 2 years of age, so, or 18 months of age, I should say. So children should be evaluated at least until 18 months of age.
Right. Great. Thank you. And what do you both actually think about the recent disappointing results of the HEAL trial, and how does this affect the other potential broad spectrum interventions? such as melatonin or other medications used either in conjunction with therapeutic hypothermia or without therapeutic hypothermia, especially in low-income countries where the authors have concluded that way.
Well, with HEAL, the question comes up, should it have been given longer than what it was, or should it have been started earlier? Because I know when the EPO for preemie trial was published, there was a very, editorial by Joe Volpe that really raised that issue. He felt that for the regenerative effects, you need to give it longer. So I don't think we know that from the HEAL trial.
Yes, I think there are multiple issues. One is even with hypothermia in the optimal population, we are not having a response in all the infants. I mean, probably it benefits a third of infants. I think the original study, it was about 20% absolute effect size. So we still have a substantial number of infants who are still subject to long-term disability or a high probability of death. So there's still a lot we need to do to, in terms of early identification of infants at high risk, maybe earlier or better maternal fetal medicine therapies for earlier identification of infants at risk, and also potentially adjunct therapies in addition to hypothermia. I mean, we have tried EPO and a few others, but then there are many others waiting in the wings. And some of the ones like, say, exosomes from mesenchymal stem cells. So I think that really seems to help for multiple organ dysfunction, including lungs and other systems, which potentially may benefit. But again, we need large randomized trials to prove their benefit and identify which population. So I think fortunately or unfortunately, there's a lot that needs to be done in this field.
But it's a very promising area of research that I would encourage all you young people to think about, because we have a long ways to go. In the HEAL trial, I did ask them what the rate of death or moderate or severe disability was, because they looked at all disability, right? So it was 29 or 30%, which is exactly what we found in the usual care group of the optimizing cooling strategies trial. So the primary outcome of HEAL to some extent was, pretty good in the quote unquote control group. And was it because they managed to prevent hypothermia? I don't know. So all the more recent studies now are taking care to make sure that there is no fever in the control infants and in the cooled infants before they are started cooling or after they are rewarmed. So that's something to think about. Yeah.
One other important important finding from the study is the follow-up rate in a setup, in a low middle income resource setup, which was 97%, which is immense. And the authors need to be commended for the amount of follow-up rate and the infrastructure that they put together to make sure that follow-up happened was just amazing to see.
They really worked very hard with social services involved and the police involved, everybody involved. They had a number of social workers that would go out with them to the various homes, no matter where the homes were, and evaluate the infants. They worked very hard. So the whole team was very enthusiastic and very committed to the study.
Dr. Ambalwan, one of the final few questions from audience: what do you think might be the mechanism that cooling caused harm almost one death per nine patients cooled. What do you think was the mechanism or scientific explanation for it?
I mean, we know, for example, that there are benefits and risks to every therapy, and the same is true for hypothermia as well. Yes, it does reduce brain inflammation, but at the same time, it also increases the risk of coagulopathy, may reduce platelet function. And we also know that there's a direct relationship between hypothermia and pulmonary hypertension. I mean, you cool an animal and the pulmonary pressures shoot up. So there are definite reasons why cooling an infant might increase mortality by itself. I mean, the advantages in a baby with hypoxic encephalopathy, you are hoping that the benefits would outweigh the risks, but it doesn't mean there is no risk.
Yes. And, you know, actually when our data analysis was done, we, and while writing the paper, we actually went back, we meaning the senior authors, went back to the DSMB and asked if we could talk to them and ask them if they had a signal at any time that there was risk. Because, you know, the in-hospital deaths were higher, but the way the enrollment goes on, they looked at the data every 6 months and they didn't see any signal. So that's why they said continue with the study. If you remember with the optimizing cooling strategies trial, where we originally planned to have 700 and odd infants enrolled, you know, we stopped at 360 or 354 because there was a difference in mortality between the 4 groups in the hospital that the data center was, the data safety monitoring committee was concerned about. But here the DSMB went over it each time and said they really, you know, just said, please continue the study.
Right. And can we take findings from this study and look back at the previous trials that were done in similar settings and build a predictive model to identify patients who would benefit from cooling rather than completely abandoning this intervention in these settings?
Sure. Yeah. I think that's a good point. Yeah.
And one of our audience, Dr. Tushar Shah, said, should future trials look at hypothermia alternatives rather than hypothermia adjuncts? Was one of the final questions from the audience.
Yeah, I think that's a good question. And part of the issue is, if you look at all the studies from the developed countries, the better developed countries, hypothermia has been proven to be effective with a pretty good number needed to treat. And some people might say, maybe you shouldn't have a randomization ratio of 1:1. Maybe if you think that the benefits are so much, you should have a 2:1 ratio. That actually might have been a consideration. It depends upon what your patient population is, I think. Suppose you are focusing on the ones with an acute intrapartum event, then I think you should probably keep hypothermia as one of the
treatment options. Yes. And I also, you know, caution folks into reading too much into subgroup analysis, because the trial was really powered for the primary outcome, not for the subgroups.
Yeah, the different question, of course, is should we weigh both outcomes the same? That is, death versus survival without disability or handicap in a lower and middle income country.
Great, excellent. Final take-home messages for our learners, Dr. Ambalwan and Dr. Shankar.
So I think my perspective is, I think this is a very well done study, really tour de force of being able to get excellent follow-up, MRI, and enrollment across multiple centers in multiple countries. Though the results don't really confirm our I would say, our assumption that hypothermia should be universally protective, I think it does bring to mind the fact that there are differences in patient populations and that they may substantially impact the outcome. That is, what works in one situation may not always work in a different situation. There's heterogeneity both in population and then outcomes.
Yeah, I agree with everything that Ambala said. And I think that, you know, this study also will, I think, push the knowledge or decrease knowledge gap by exploring different aspects of it. Because I know, you know, genetic markers are going to be looked at, spectroscopy is going to be looked at. So there will be a lot of information that will come out of the study that will help us to understand cooling better. So, you know, I think trials that are negative can for the authors can be disappointing initially, but I really think you can learn a lot from them. And you know, secondary studies are always helpful and add to the knowledge gaps.
Great. Great. Thank you so much, everyone, especially the audience. We had some great questions from several audience today to make this discussion exciting. And I want to congratulate and also thank Dr. June for a great presentation. Your slides were terrific. You engaged the faculty mentors at the right spots, and you did a phenomenal job covering this extensive paper. I also want to thank our faculty mentors for making time to not only discuss the paper, but also teach the earlier generation in the audience. And there is a feedback survey link that was posted in the chat box. Please respond to that survey and provide your direct feedback so that we can improve our future sessions. Our next journal club session will be on the May 18th, and we will circulate the registration link pretty shortly in the chat box. Please do join us, and thanks everyone for participating today. So,
thank you for having me.
Thank you.
Thank you.
It's been great.
Thank you.
Goodbye.
Angie, you can wait once like everyone get off. I'll